So I kind of want to just, we have only a short bit of time, so it's a lot to cover regarding osteoporosis, from screening all the way to treatment and prevention. However, that's kind of my goal, is to kind of give the nuts and bolts of understanding those who are at risk for fracture and those that we should be screening. How do we understand the results when we do screening to decide and manage our patients, and then talking briefly about the medications that we can use and supplements as well. So just to first talk about osteoporosis and its prevalence and why it's so important. First, it's very common in older adults. As we age, our risk for fracture alone by age increases over time. And as you can see, it's become a significant component to our public health problem. Over 10 million Americans have osteoporosis, and that results, unfortunately, in a lot of fractures and injuries. And that's what's really kind of the downturn for an older adult as they age. The 1-year risk for mortality alone in older adults can range anywhere from 8 to 36%. And I think what's more important about this is understanding that though we think of osteoporosis as a disease that affects women, it's actually that a lot of the problems and the sequelae of having osteoporosis can be really detrimental in men too. And granted, I live in the VA. I treat a lot of men, so I tend to be a little bit men focused with my clinical care. But however, I think it's important for all of us in community practice to realize that this isn't a problem that affects both men and women and has a lot of detriment to their overall function and independence and quality of life. So just to kind of give you an idea of what is going on in osteoporosis, and I use this picture to actually also talk to my patients. So I say, normal bone is kind of like a strong building that's made of steel. Okay, and what happens with osteoporosis is that the natural process of remodeling kind of gets weighed in the sense of that more reabsorption happens than laying down of bone. And so what you get is this kind of poor stratus of micro-architecture that is at high risk and susceptibility to fracture, creating a very brittle environment. So to kind of talk about how bone loss occurs over age, we're going to focus first on women. And so as you see, we all obtain our peak bone mass roughly around the late 20s to early 30s. And that is primarily dominated by, your weight-bearing activities, your calcium and vitamin D intake or exposure, being sun, and making sure you kind of have a healthy lifestyle. But there's obviously things early on in our lives that can affect reaching peak bone mass, primarily in women if they would undergo some sort of early menopause due to some sort of removal or reduction in estrogen. If they become immobile for some reason, like if they're laid up for several months generally at a time, they had some major trauma injury and they were in a bed, astronauts, so to speak. Things like that can affect peak bone mass. And then all women generally, about the ages of 40 to 50, undergo a significant loss in estrogen when we hit menopause. And that obviously translates into a huge drop in bone mass. And that's why, again, we think of osteoporosis primarily as a women's disease, just because we see it earlier for this reason. But aging alone also has a significant effect on the reabsorption and remodeling process. So that's a big part. I think the male slide not make it? I think. Oh, there. Sorry. Excuse me. So for men, our peak bone mass is also roughly about the same ages. It gets a little higher just because of testosterone and probably sometimes activities that men could be doing maybe more so than women. And then as you see, they kind of go through a plateau during the time when women would generally have been losing their bone mass during that kind of mid-adult to older adult range between the 40s and 60s. However, after about the age of 70, men undergo a gonadotropin loss, so loss in testosterone. That's actually normal and part of natural aging. And that's actually also translated into a loss in bone mass that we see. So as you see, so when we lose the gonadotropin there, they have a loss in formation, increase in reabsorption with aging. And so that's what puts men at a particularly higher risk when they get into the 7th to 8th decade of their life for fracture and let alone mortality versus women, which was a little bit sooner. I'm just going to flip back. to make sure that I didn't miss. I think, yeah, that's fine. Sorry. I think this just got a little out of order, so I apologize. So just to kind of go over some risk factors that can occur during time, both during those early formative years of building bone formation, let alone can also contribute throughout the rest of the 40s, 50s, and 60s decades of life, let alone into older age. That can be big risk factors for bone loss, and I think are good things to obtain during a history when you're trying to see your patient and recognize, are they at risk for osteoporosis? Is this someone I should get a DEXA in? So particularly lifestyle factors and things that I see a lot and that probably refers men to us at a much younger age than 80 into our clinic is alcohol overuse or abuse and smoking. Those are huge, huge risk factors, both which are risk factors if there's active use for ongoing bone loss and fracture risk, as well as just risk for having low bone mass and bone density to begin with. Obviously, there's a host of different medical conditions that can increase your risk. Primarily, like we talked about, different reasons for having low estrogen or low testosterone, either primary or secondary to underlying diseases. A lot of people who have inflammatory or autoimmune diseases, that too, that inflammation chronically within the body reduces the bone mass as well and has effects on that. Any person who's undergone chemotherapy and different types of treatments for that can also be at risk for bone loss and cirrhosis, as well as AIDS, and HIV, not only just due to some of the medications that they could be on, but the disease itself. The medication that we commonly think of as the biggest risk factor for bone loss are the glucocorticoids. So a person needs to be on a dose generally about 5 or greater, roughly around 7 milligrams a day or greater for over 3 months to really have significant. But however, if they're a COPDer, and they're getting multiple bouts of exacerbations and getting, several sets of probably roughly about 5 to 6 good long tapers of steroid throughout a year, that's probably the equivalent to being on a chronic steroid of about 7 milligrams a day for about 3 months. Some, I would say some like SSRIs can have a little bit of an effect, probably not as great as things like prednisone. And definitely from anticonvulsants, it's not all anticonvulsants. Generally, it's like phenobarbital. That's probably the biggest offender. We all like to think about PPIs as a big issue. I think the jury is still out about how significant those are. I probably would recommend if you're having a really hard time getting a person's bone mass up and they're very maybe concerned about taking like a bisphosphonate or something like that, that could be one thing you could consider as an alternative to other ways to how to help their bone mass and bone health. And then obviously the big thing I want to kind of point out, I'll point out a little bit later about nutrition, but understanding a person's calcium intake is really important. I think a lot of people actually do not get a lot of dairy in our diets. I guess that's hard for me to understand because I probably go through a tub of Nancy's. It was just this massive yogurt a week. So, but it's always interesting when I ask my patients, are you a big milk drinker, eat cheese and stuff? And obviously, a lot of people don't get it. And as we age, our ability to absorb calcium actually declines due to changes in the receptors in the bowel. So for that reason, if they're already not getting a lot and they're already having a hard time, let alone the little bit they do get in, absorbing it, that's a huge factor to part of the reasons for ongoing bone loss, particularly as we age. Vitamin D, particularly all of us who live up here in the Northwest who've had the winter that we've just had and continue to have, do not have really great exposure to sun. And so oftentimes we find vitamin D deficient people, and I'll talk a little bit more about those hopefully a little bit later, but just those are the main nutritional things, let alone if a person's had, and I would say this is probably the most common thing that we get referred, are people with some sort of gastric, abdominal kind of revision or bariatric surgery. We see a lot of those people, mostly just, again, related to the calcium and vitamin D issue and just the fact that they're having a hard time reabsorbing things. And lastly, family history is huge. So particularly in a first-born relative, so if it's a parent or a sibling, and particularly if they've had a hip fracture or fracture themselves, that's a big reason. So we're going to talk next now about does the person have osteoporosis, and talking a little bit about DEXA scores. So osteoporosis by itself is actually defined by a score, which I find kind of funny. And we'll talk a little bit about that when I explore kind of the pitfalls of DEXAs, but is truly defined by a T-score of less than negative 2.5. And what that means is that you obtain a bone density of a person, either in their hip or their spine or both, and you compare that to a general population of healthy young 30-year-olds. And if their bone density is 2 or 2.5 standard deviations below what we think normal should be based on this population of healthy 30-year-olds, then we say they have osteoporosis. Osteopenia is in the gray zone between -1 and 2 and 2.5. It's kind of like a at risk, but however, a good portion of people who have osteoporosis will actually go on to fracture. So it's not like necessarily a safe zone to like remain in, but I think it's a zone to clinically ask yourself, even though this DEXA is telling me osteopenia, could they still be at risk for fracture? And what are the other things that I need to consider before starting treatment? And then normal is anything above -1. The other thing that also defines a person to have osteoporosis if they've had some sort of like minimal trauma fracture, and generally that means they had a fall and they fracture. We sometimes categorize, coughing episodes and then getting a rib fracture. It's a little bit dicier, but I would also generally recommend that that's probably a minimum trauma fracture. Also, like compression fractures in the spine from doing, again, very minimal work. I've had patients who even just do simple like physical therapy exercises and have gotten compression fractures, and obviously that's very concerning. So even if they have an osteopenia DEXA or rate on their DEXA and they've had a fracture, they'd have osteoporosis. So let me talk a little bit about the pitfalls to DEXAs. Like I said, DEXAs are highly variable depending on the reader, right? They're doing they're drawing little boxes around the hip and the spine and really relying on the measurements and how well they're able to do that. And so there's several things that can make the bone density look a lot higher than it is, particularly if their person has any kind of degenerative disease or sclerosis in their hip. That can make it look like there's more calcium. Also vascular calcifications in the aorta can be picked up, particularly in the spine. If they have like scoliosis or other kind of anatomical changes, that can affect the spine. So things like that. So it's always good to know that and also take a grain of salt when you're reading a DEXA. So I think there was a question about like kind of when to repeat DEXAs, and I would say partially if you get a DEXA back and it's a normal DEXA, really the best recommendation is to probably do it every like 2 to 3 years. It's particularly if you're not worried about anyone having a lot of like reasons for ongoing bone loss, like on a corticosteroid or something like that. For people that are treated, however, I would recommend probably getting DEXA follow-up based on the treatment, but again, it's usually roughly about every 2 years that we do in clinic. And that's just due to the fact that there's a lot of inter-rater reliability, or poor reliability, so sometimes there can be a lot of variation, even just within a year. That's actually not due to the therapy, and that's just due to the reading itself. And so finally, I just kind of want to wrap up here and talking about who and when to treat, okay? So again, just to reiterate just the age relation to fracture risk. And so when we do think about fractures in our populations, we have to consider age as a big factor to when you might want to start a bisphosphonate or think about starting therapy to prevent fractures. Mostly because, as you see, there's a sharp increase especially in women, after the age of 70 for their risk of hip fracture, and then men, kind of like I said earlier, after the age of 75. So the main components to kind of going through your head and saying, is this person at really high risk of fracture, are the components that I've listed here. And these are also the components that are in a FRAX, which I'll show you, I think, in the next slide or two. Basically, if they personally have had a history of fracture, or there's a family history of fracture, are two big components that really weight that. The current glucocorticoids are also a big factor, as well as smoking or alcohol drink. Things that aren't included into the facts are history of falling, weakness, imbalance, and gait disturbance, but I can tell you that in our clinical practice, we use that as a method too, to kind of sway us. Someone who's kind of borderline, but they have a lot of immobility and we know they're high risk of falls, we might be like, let's go ahead and probably treat them because we're so concerned that they will be having falls and fractures. And so this is a picture of a DEXA, of a FRAX that was completed, just to show you like what it looks like on the internet. You can just Google FRAX and the tool should pop up. You pick your location, meaning are you in the US or are you somewhere else in the nation? Do you have a Caucasian population? And then you go through and add in all these demographics about your patient, what their age is, what their weight and height is, and then you click in all those questions like I had showed you about risk factors, and then you include their T-score either as an actual T-score or a BMD, and then it will calculate this probability, 10-year probability risk of fracture. And what that's important is because that's really what helps you determine, is this person at high risk of fracture, and are they at a level that epidemiological evidence has shown that treatment outweighs, and the benefit of treatment outweighs the risk of treatment. And generally that cutoff is at 3% for a hip fracture and 20% for a major osteoporotic fracture. So as you can see in this patient, even though they're only at 16% 10-year probability of a fracture for major osteoporotic fracture, they're at 6.4 for a hip fracture, and so therefore we would go ahead and treat them. Briefly, just to talk about calcium and vitamin D, I just wanted to put up here some information about how to elicit current dietary intake of your patients so that you're not over-prescribing calcium. And I think that's where really we've run into trouble with the calcium in this day and age of calcium was kind of the in vogue thing, and then now it's become the kind of sometimes out of vogue thing, and concerns of risks related to kidney stones and cardiovascular. But I think it's just really important to know that if they are taking in as much calcium as I am in my diet, they probably don't need a supplement. And the way to kind of calculate that is just saying a glass of milk is equal to 300 milligrams. A slice of cheese is equal to 300 milligrams of calcium. And then really they should just be beefed up to about 1,000 above that, or to 1,000 total with additional supplements. For vitamin D, the recommendation is kind of a little bit all over the board depending on who you talk to. And what guidelines you want to follow. However, I usually try to keep a very simple thing for my patients, and I say 1,000 of calcium and 1,000 of vitamin D. Obviously, there's patients that probably 1,000 is going to be too much, and those are the people you just kind of have to monitor. But roughly anywhere from 800 to 1,000 is probably a good amount per day without going into risks of too much. And then finally, bisphosphonates. I just wanted to list them up here briefly for you. These are the medications that are first-line therapy for patients that you do determine are above those risk thresholds that I mentioned earlier, or have actual osteoporosis. And these would be what you start. And generally we start with oral bisphosphonates before IV, those being either alendronate or rizogenate. And really the reason is because they reduce the risk, they've been shown to reduce the risk of hip fracture, not just BMD increase, which is an important measure, but really showing that there's fracture data that reduces the risk of fracture, and that the number needed to treat to get such a significant, it was actually 50 to 90, which is pretty impressive. So there's a lot of side effects and a lot of concern out there, and we can talk more about that. But I do always have a very informed conversation with my patients before starting them, so that they know what they're getting into. But I would have to say in clinical practice, the biggest side effect that we see is the heartburn and the esophagitis. And just counseling them through that is really, really helpful. And then if they can't tolerate, then that's when we generally go to an IV form. So in summary, like I said, T-scores less than negative 2.5 in a trauma fracture is technically the definition of osteoporosis. However, other people with osteopenia might be at risk for fracture. It's extremely common and increases with aging and associated with really high morbidity and mortality. So it's something to be on your radar for screening. You use the bone mineral density as well as risk factors to assess for fracture risk, so it's not just BMD alone. And really important to think about lifestyle changes and calcium and vitamin D supplement when you're starting and initiating therapy. And then finally, the part that I didn't kind of left out in this is just thinking about fall prevention in addition to your calcium, vitamin D, and bisphosphonate. Because more importantly, fall prevention is probably what prevents fractures than just giving them bisphosphonates and calcium and vitamin D.